I don't have, oh, now it's perfect. Hi, welcome everybody to the Health Occupations and Long-Term Care Subcommittee. We have 8 bills on our agenda today, so we will do our very best to get through all of them, but we do have a hard stop at 1 o'clock. So we will do our best to get through everything that we can, stop at 1 o'clock, and if we need to, meet again on Monday. I believe at 1 o'clock, that I think should be on the public calendar. We are going to start with House Bill 1022. Aaron, do you want to tell us about this bill? And I know we have some amendments that we're also going to be discussing.
Yes, so House Bill 1022 requires a nursing home to submit electronically clinical information to the state designated exchange and authorizes the exchange to provide that information to a healthcare provider, an authorized health information exchange user, a health information exchange authorized by the MHCC, or a federal or state official. If approved by the MHCC, the information submitted may be combined with other data maintained by the exchange to facilitate a state health improvement program, mitigation of a public health emergency, and improvement of patient safety. There are amendments on page 3 of the bill beginning on line 19 that require an electronic health network to provide electronic healthcare transactions to the exchange for certain public health and clinical purposes. The bill prohibits an electronic health network from charging a fee to a healthcare provider, a healthcare payer, or the state designated exchange for providing the information. On page 4 of the reprint in lines 11 and 12, the bill authorizes the MHCC to adopt regulations that provide for a uniform gradual implementation of the exchange of clinical information. The bill requires that the regulations adopted by the MHCC limit redisclosure of financial information, including billed or paid amounts available in electronic claims transactions, restrict data of patients who have opted out of record sharing, and restrict data from healthcare providers that possess sensitive healthcare information. I sent an amendment in addition to the packet in a subsequent email, and this amendment would clarify that the state designated exchange may provide the information that's provided by nursing homes to the various entities only to advance the policy objectives that are listed in the bill and may not be used for any other purpose, including licensing and certification. And although these amendments were sent to you separately, they can go together. They don't contradict each other.
Perfect. So, and we can consider them as one group of amendments then? Or
yes, you can.
Okay, perfect. So, questions from the committee about the bill, or do we want to go ahead and adopt the amendments and then discuss the bill? I think it'd be great to adopt the amendments. Does anybody want to
move the amendments?
Second.
Moved and seconded. Okay, any discussion specifically on the amendments before we discuss the bill as amended? Raise your hand if you want to say anything. Otherwise, all in favor of the amendments, say aye. Aye.
Aye.
Anybody who's opposed, go ahead and raise your hand in the side and we'll note that, but I'm not seeing any hands. Okay, so we've adopted both sets of amendments now. So let's move the bill. I'll move the bill. Move the bill as amended.
Second.
All right. Any discussion on this bill from the members? We have stakeholders here who can walk us through what it does. I know we're time sensitive, so we want to know what it does, but also know we've got all these other bills on the agenda. Who wants to tell us what this bill does now that we've put all these amendments on? David, would that be you?
So I might suggest we invite Craig to overview as a first step, and then I can join in on the discussion.
Okay.
Morning, everyone. Craig Bean.
Yep. So I'll be very brief. Thank you all. Craig Bam. I'm the executive director for CRISP, our state designated health information exchange. The bill basically does 2 things, as Aaron read. It provides more nursing home data, which is very similar to the infrastructure that was developed kind of rapidly in response to COVID. It would allow kind of longer term services to be available so that if there were new programs or in partnership with the public health care model, we could have things like bed capacity, different healthcare clinical data from nursing homes, which we have Dana Kaufman here, but I think is a really kind of essential way to bring nursing homes into kind of the broader healthcare industry and the exchange process. The other thing it does is provide electronic health network transactions to come through CRISP. And so this would be a way to get really broad, widespread connectivity to providers who today are not as connected. It would allow us to do things like present who a patient's care team is, or to understand if an encounter happened at a place like an urgent care, which obviously is really important right now, but also just generally as we think about the model.
Oh, yeah, cool. Thank you very much.
Who is it that has some noise in the background? Can you make sure to mute yourself if you're having a conversation in your office? Okay. Thank you for that. David, do you have anything to add?
So I think Craig did a really good job teeing it up. It is a bill that's a public health related bill. What the bill would allow for is taking advantage of electronic health information and making it available to healthcare providers in near real time. So there are many advantages to public health to building on the great utility that the state designated HIE has been able to put in place, particularly as we think about meeting the requirements of the pandemic. And the information that we would be using from electronic health networks fills in a vital gap for patient care and for public health purposes. So I'm happy to answer any questions if they arise from the committee.
Wonderful. And I know, Dana, someone mentioned your name, so do you want to weigh in? No, because you're muted, so.
I know, I gotcha. No, I'm good, and I know we're in the rush, so I don't need to add. So thank you for adoption of the amendment.
Okay, and then Care First, is there someone from Care First who wants to weigh in? Because I know you worked on amendments too.
So, hi, so yeah, it's Debbie. We worked with CRISP and MHCC on the amendments, and we're comfortable with the amendments as drafted.
Great. Any questions from the committee on the bill as amended? Oh, I see some. Perfect. Delegate Krebs, then Delegate Riley. Delegate Krebs.
Yes. Who determines who has access to this information at the nursing home level? Or how's it determined?
So maybe, Dana, I'll take the first part and you could maybe do the second part. So from kind of the broadly through the HIE, people are allowed to access data for permitted purposes, which are generally aligned with treatment or in some cases operations such as care management. So most of the nursing home data would flow along with patient health records in the way other healthcare data does, which also allows for an opt-out for patients who don't want their data exchanged.
Okay, and is that opt-out provision, is that something that is shared with the patients, or is there some procedure to allow them to know that they can opt out?
There is, yes, separate from this bill, just in the HIE regulations, when a patient meets with a participant of CRISP, so if you go to your doctor's office and they're participating and sharing data with us, then they give you the opportunity to opt out.
And that happens at each encounter, like, so there's different options at different times of your whatever that you can opt out opportunities. Okay, all right, thank you.
Yep. And then some of the amendments on the data use for the nursing home data did things to limit how things like policymakers could use the data only for broader population health programs, not for licensing or certification.
Excellent. Does that answer all your questions, Delegate Krebs? Perfect. Delegate Riley.
Thank you, Madam Chair. Yeah, kind of piggybacks onto Delegate Krebs. Some of those were mine as well. So basically, so currently the physicians, they use the CRISP, okay? And then also hospitals use that same system. So we're just moving this over to the nursing home. So where if the patient opts in, then all of the records from the physician and the hospital follow over to the nursing home. Is that how this works? Is that why we're doing it?
I'm sorry, go ahead.
So the consumers, the patients opt out. The way it's structured in Maryland and most all states nationally with HIEs is that the consent is to opt out as opposed to opt in. Consumers can opt back in. And when I say consumers, it could be the patient, the caregiver, or someone in the family, but it's an opt-out model. And Craig, you may have something else to add.
Yeah, and then the way I think about the data flow is really like the HIE is almost a healthcare utility. And so we're connected to hundreds of different healthcare practitioners, hospitals, physicians, as you said, and they all share data with us. That data is available to nursing homes today, and some nursing homes share some data with us. What this bill would do is allow for more data to flow into CRISP for more purposes, or just more kind of breadth of what we share with different physicians.
Yeah, and it's really critical for care coordination and care transition to have complete information on nursing home residents.
Okay, and then I guess a follow-up, when during the committee, I understand that is there only a one-time fee and that's paid by the physicians? Or is there a fee?
Craig?
Yeah, so CRISP is
Or-
funded through a couple of different mechanisms. There is a participation fee that is paid by hospitals and insurance companies, the payers. We also are essentially granted money through the Rate Setting Commission and through the Department of Health. And then we can leverage some of those state grants to get federal funding, either through Medicaid or through other programs.
But by adding this extra data through the nursing homes, it doesn't cost an additional fee if they're already using
Correct.
an in HIE. Okay, all right. Thank you very much. Appreciate it. Thank you, Madam Chair.
No problem. Delegate Bagnall.
Thank you, Madam Chair. And I just wanted to make sure that I was clear that as amended, we're able to have greater data sharing, which means we're going to have more effective data reporting. And we feel like the stakeholders are comfortable in the amendments that we're going to have access to the data that we need. Is that what I'm hearing from everybody?
Yes.
Thank you. Thank you, Madam
Sounds
Chair.
like it. We hear no complaints.
Love to hear.
That's what we need. Perfect. So that is the last question from the committee. The bill has been moved and seconded as amended. All in favor of the bill as amended, say aye.
Aye.
Anyone who wants to oppose, go ahead and raise your hand. I'll give you a second, but I'm not seeing any hands. So this bill is going to fly out of here unanimously. And thank you, Erin, for being with us today. We're going to do next Tyler's two bills. So we'll start with House Bill 604, which is Delegate Kippy's bills about unclaimed cremains. Tyler.
House Bill 604 would require licensed funeral establishments or crematories who are in possession of unclaimed cremains of a veteran or the eligible dependent of a veteran that has not, of which a veteran service organization has not taken possession, so that the Maryland Department of Veterans Affairs would be notified of the status and then transferred to the department for appropriate disposition.
Okay, and we don't have any amendments on this bill, right, Tyler?
Correct.
Move the bill.
Move favorable.
Let's make sure
Second.
we have the stakeholders. Sharon, are the stakeholders in the room for this, or do we have anyone?
What did she say?
Okay, so the
He's
bill has been
connecting
moved
now.
and seconded. We're getting the stakeholder in the room, just in case there's any questions. But it sounds like, raise your hands if we've got questions. It seems like everybody likes this bill, is what I'm gleaning. So as they're connecting, I can go ahead and call a vote. Jim, we're just moving the bill. So unless you want us not to, we'll go ahead and vote it out.
Correct.
Sounds like he's good with that. Okay, so all in favor, say aye.
Aye.
Anyone opposed? Raise your hand. Looks like it's going to be unanimous. Great bill from Delegate Kipke. Thank you. Now is the time in the agenda where I show you all my moment meditation drink in a can as seen on Shark Tank. This is what we will need for the rest of our agenda. Take a moment of Zen because we're getting to the more complicated end of session bill. You know, welcome to health occupations. Everybody has an opinion and an interest. So our job is to do our very best to meet everybody's needs. And at the end of the day, you know, make a policy call based on what we think is going to be in the best interest of the people of Maryland. I'm saying that because we're about to get to some bills that are not as easy to pass as the last two were. So let's go ahead and talk about Tyler's last bill so that he can be excused for the day, which is the audiology compact, which I think is in pretty good shape. And then we'll go back to the psychology compact, which we picked up last week. Tyler.
House Bill 288 would enter Maryland into the Audiology and Speech Language Pathology Interstate Licensure Compact upon the enactment of the compact. There are currently 6 states that have enacted legislation for it. So another, after Maryland, there would be another 3 states needed, total of 10 states to for the interstate compact to come into effect. I'm not aware of any other amendments or any amendments proposed for it.
Okay, Delegate Charles, do you want to say anything? And do we have folks here on this bill that we need to talk to?
Thank you, Madam Chair. Yes, we have Nahali and we from the Council of State Governments, and we also have Angela Mazzomo from the Maryland Speech Language Hearing Association. So I'd like to bring them on board to start talking. As I stated earlier to you, we have worked through all of the issues from the Maryland Society of Otolaryngologists. Oh, that's a long.
Otolaryngologist, yes.
Yep.
Otolaryngologist.
Yes, we have worked that out. We have worked the issues out with them as well, and also with the Maryland Academy of Audiology. So I'd like to bring those folks on board to move forward with any thing they want to bring to the table.
Great. Who is here who would like to speak? Go ahead and speak up.
If I may start, if that's okay, can you hear me?
I can hear you, but I can't see who it is because there's no name. So please introduce yourself.
Absolutely. Thank you so much to our delegates, and thank you to this committee. I really appreciate the opportunity to be here. My name is Nahali Kalpis. I am legal counsel with the Council of State Governments. I was a co-primary drafter of this compact, as well as the Occupational Therapy and Licensed Professional Counselors Compact that I believe has already passed through this committee.
Yes.
And I'm just here to speak on behalf of the bill. And I'm glad that we've worked our issues out. I think this is an important piece of legislation that Maryland has had the prescience to consider. And of course, you've already enacted the IMLC, the NLC, PT, I believe, and I think the EMT compact as well, that my group, Council of State Governments, has a part in. I just wanted to let you know that we have board and association support. And of course, that OT and LPC that have moved through your committee, they are exactly the same model. They operate in exactly the same way that this compact operates. There are no differences. It is the mutual recognition model, which has an added benefit of having been identified by the Federal Trade Commission as an effective tool to ameliorate antitrust concerns in their 2018 white paper. This compact, like other compacts, respects the notions of transparency. It respects the notions of very narrowly tailored rulemaking that only speak to implementation and administration of the compact and do not speak at all to scope of practice. That retains that authority is retained solely within the Maryland board. And I want to be respectful of your time and just be available for any questions that you may have. Thank you so much.
Thank you. Let's hear if we have anyone else to speak on this before we go to questions. Is there anyone else in the room who'd like to talk on this?
This is, whoops, can I, Barbara Brocato?
Yes.
So on behalf of the otolaryngologists, we did sit down with the proponents, actually with Susan Adams, and I don't know who was on the phone, and we offered amendments that were agreed to with the exception of one, but we did not see those agreed to amendments in the packet. So I see nothing in the packet that reflects the amendments that were agreed.
Oh, that's a really, go ahead.
I believe I can address this, and of course, if our sponsoring delegate would like to respond as well, but in fact, we did have some lengthy phone calls, and during those phone calls, I believe it was 8 out of 11 proposed revisions were agreed to by Council of State Governments and ASHA for this bill. However, we never received a response to that response from the otolaryngologist, I believe, and maybe MedChi, but certainly the otolaryngologist. We did not receive any sort of response, but I will let our sponsoring delegate certainly speak to that further. But my understanding is we never heard back after, we sort of put the ball in that court and never heard back.
Well, I guess there was some misunderstanding because we got confirmation over in the Senate from the Senate sponsor. We reached out to Delegate Charles.
Ms. Brocato, do we have Senate amendments we can work from? Did the Senate draft the amendments?
Yes, they do.
Okay.
And we have it drafted into the bill in the Senate, what was agreed to. We removed our opposition with these amendments. The one thing that is still outstanding that we ask to be considered in the future at some point is, in Maryland, we have 2 physicians on the speech and speech language and audiology board. And we ask that there be consideration of an amendment that would allow the possibility of a physician being on the compact board.
So let me just take this in 2 separate buckets because I want to make sure we can keep things moving here. It sounds as though there are amendments that are not in our packet, but the Senate has them. So Tyler, can we work between now and, you know, whenever we would vote this out of full committee to get those amendments? Is that, Tyler, is that something we can do? Or should we hold this bill until our next meeting until we can have the amendments before us?
We could take that approach. I don't know what the amendments, how extensive that they are and like what kind of policy would be affected by it. If they were agreed upon by, you know, CSG and ASHA, my guess is then they would be within line of the compact and not have any kind of policy implications that would affect the impact of the.
Well, let's ask the sponsor.
So yeah, we'd have to know that.
We could either hold, you know, are these, I guess, Delegate Charles, are these amendments that you're supporting and the Senate sponsor is supporting as well? And we just need to get their physical, you know, we need to get a hold of them so the subcommittee can look at them.
Yes, yeah, that's fine. I'm willing to do that. I also have somebody in the waiting area right now, Davion Percy.
I'm sorry, what's the name? You kind of went in and out.
Davion Percy, he's in a waiting room right now to give a little further.
Okay, Sharon, can you make sure we get Mr. Percy in the room here? I'm not too worried as long, you know, it sounds like things are pretty cleaned up, and we can discuss this bill now, but if we need to hold the vote on it till our next meeting, I think that'll be fine. We'll still get it out before crossover. I see, looks like Mr. Percy's in
Yeah,
here.
he's in. Davion, can you go ahead and clarify some of these issues for me?
Yes, absolutely. Davion Percy. On behalf of both Masha and Asher, we had a last minute change. But yes, we did work on some amendments. The Senate moved forward with putting those amendments in. We thought they were in on both sides, but it appears that they're not. However, the amendments that we agreed upon still qualify. They're mainly technical in nature. They will still allow us to be entered into the compact. So we don't have any issues with that, but we can make sure that all the paperwork gets caught up on both sides very quickly, because that's not a problem.
Excellent. So then I guess our next set of questions, and we'll go to Delegate Krebs's question, is sort of the second issue that Ms. Bricado was talking about, which I guess is the issue of whether we were to add a physician to the board. That, my understanding, tell me if I'm wrong, that wasn't agreed to because it would violate the compact. It would be different. Is that the issue on that one?
Yes, that is
Taking my
correct.
question,
And I'll
that's
let Nahali.
Sorry, Delegate Krebs. Great minds.
Sorry about that.
So, I'm sorry.
Nahali, did you want to speak to that?
I'm so sorry I can't. I'm sorry that I'm participating by phone. I'm actually traveling to the great state of Maryland right now. But I would say that in terms of the physician member add-on, unfortunately, that is a substantive change that would change the nature of the bargain for the other preceding 6. And as of this afternoon, it may be not 8 states that have already joined the compact. That would be a substantive change because not every state has physician members. And there are a number of states already in the compact that do have physician members, but understand that the physician member can have input in alternate ways. So unfortunately, that is something we certainly would consider, you know, some sort of ability for committee participation by physician members, but it would so drastically alter the nature of the compact, which is both a law, a compact law, and a contract. So if we change the substance of the offer, then we don't have sort of a mutual agreement there, just in terms of contract principles. So unfortunately, that's something we can consider in different ways, but we can't consider in terms of delegates to the commission. The other amendments are all fine. I've been receiving text from Susan Adams with ASHA, and she did say, and I don't know, I think we can certainly work and get amendments today, but she did make note that the Senate sponsor had said no amendment. So I don't know if that's clarifying at all. I don't want to confuse issues, but certainly if those need to come back in, we can certainly do those, because there have been, I believe, again, 8 out of 11 agreed to, highly technical in nature. They originated from the EMTs. So those are things that we have agreed to. And then, as mentioned, there are a few that we just can't, that are substantive. So we could certainly do those, and we can get those to you today. And I think the Senate sponsor was okay without amendments, but if they need to go in, we'll make that happen.
Okay.
So Delegate Krebs, does that answer your question, or do you have?
Yeah, so right now, I think let's have consensus that the physician amendment is not something that can be done, and it's the supposedly technical amendments in the Senate that don't do a lot. So we just need to know what exactly they are, and if they're going to offer them in the Senate, and then get this thing moving.
So we'll make sure we get that over to you today.
And everyone's fine with these supposed technical amendments. There's no substantial changes to that.
Agreed.
Okay, that's so conceptually we know what we're doing. Thank you.
Okay, Delegate Cullison.
Thank you, Madam Chair. I think I heard Ms. Brocato say that the physician issue, it doesn't need to be resolved now, but something to consider in the future. So I think, it sounds to me like we're really on the path of moving this bill.
That's certainly what it sounds like to me too. I think that all we need is the language in front of us of those technical amendments. So,
Right.
I would rather have them in front of us, since there seems to be a little confusion as to what they're going to be, rather than move them in concept right now, since we don't have clarity on that. But we will put this on for a quick vote at the top of our next meeting on Monday, so we make sure to keep this moving, because it seems as though, to me, all the issues are resolved. Is there any other members who want to raise their hand to either tell me my plan is ridiculous or ask a specific question?
Your plan is great.
Awesome. Excellent. Well, then let us move on to SIPACT, House Bill 970, which is Lisa bill. And thank you, Tyler, for your work on these. And I guess we'll see you Monday.
All right, let us have a second to get everybody in.
And we do have, I know we got some messages in my office that we have a replacement psychologist here today. Unfortunately, the psychologist who was here with us last week is ill. But we do have stakeholders here to give us an update on how their progress went in terms of working out their issues that we discussed last week. I would like to, if possible, vote on this bill today. I don't want us to get too backed up. Some conversations can just go on indefinitely if we let them in this subcommittee. So if the committee feels comfortable, I think it would be good to take a vote on this one today after we have all of our questions answered. I see Mary Alvord. I know she is the psychologist who's going to be speaking. I see, who else do we need in here? Do we know if Delegate Johnson's here already? Perfect. Delegate Johnson, while we're, do we have someone from the psychology board in yet? Let's make sure. Oh, good. Excellent.
And Lorraine Smith is also within the waiting room, I believe.
I was looking for her. Oh, there she is. She's in the meeting. Ms. Smith, are you here in the meeting?
I am.
Excellent. Wonderful.
Good afternoon.
Good afternoon. Okay, let's start with Delegate Johnson.
Thank you, Madam Chair. And I'm here today to talk about the Psychology Interjurisdictional Compact Bill, the SIPAC Bill 970. Thank you for letting us come today and tell you a little bit more about this bill. We had another meeting with the Psychology Association and the Board of Examiners, and I'd like to thank them for sitting down together again and trying to hash some more of this stuff out. There were a few questions by the board. Again, they brought up the issue of the educational requirements. And again, the association let them know that the SIPAC required an e-passport, which does require a doctoral degree. the board did bring up a good question about what if it was an older e-passport that was not certified? And the answer to that was they would not be able to practice in SIPAC. They would not be able to be part of SIPAC. The association was going to send the board the exact location, the code number that was in the SIPAC regulations that specified the e-passport with the educational requirements. We talked over the concerns about having a criminal background, not being allowed to practice in SIPAC. They still would be able to practice in Maryland, just not be part of SIPAC. The board continues to support the governor's bill, which does a lot for psychologists outside the state of Maryland, but not really anything for psychologists in the state of Maryland. That would allow psychologists from outside the state to come into Maryland to practice, but it would not allow our psychologists in Maryland to practice outside the state. And right now we have the District of Columbia, Pennsylvania, Delaware, Virginia are all SIPAC members. And West Virginia is expected to introduce this SIPAC legislation during this legislative session. So everybody that's contiguous to Maryland would be part of SIPAC, and Maryland would be left as an island in the middle that would not have the opportunity to practice outside the borders. And that concerns me, because why then would you want to come to Maryland and get a Maryland license? Why would you not go 20 minutes outside of our borders, get an office and make that your home state to be licensed in, and then be able to practice in 16 states and jurisdictions? So hopefully the board got their concerns about the education answered to their satisfaction, and we can move forward with this bill that really is about access to care. We do have with us today the executive director of SIPAC and the SIPAC attorney. The executive director is Janet Orwig, and the SIPAC attorney is Doug Wolfberg, to answer any questions that the committee may have today. So with that, I'm going to pass it on to one of the panelists.
Thank you. So let's hear, I know we'll have questions from the committee, so I don't want to take too long, but since we do have Janet Orwig, and I think you said Doug Wolfberg here, I would love to just meet you guys, and also if you could really clarify in one sentence or not whether a psychologist who doesn't have a PhD can practice under SIPAC, that would be great.
Good morning. I am Janet Orwig. I am the executive director for SIPAC. Thank you very much for the invitation to come and talk with you today. As it stands, that a psychologist without a doctoral degree would not be allowed to practice under SIPAC. There are several mechanisms within the document itself that does talk about graduate degree, and then the rules that the commission has firmed up in its definition section defines graduate degree to be a doctoral degree for the purpose of the compact. The e-passport certificate also requires that you have a doctoral degree from an APA, CPA, or designated program in order to participate. And the question that I heard a moment ago dealt with if it was an older e-passport. The e-passports actually were not even open for applications until July of this year. Well, actually July of 2020, excuse me. So that we had all of our rules in place, as well as the policies, and that the commission voted on agreeing with the APA, CPA, and designated requirements. So aren't any e-passports that are older and would not have fallen under that qualification. Thank you.
Wonderful. That's very helpful. Do you have anything to add, Mr. Wolfberg?
No, I don't. Thank you.
Okay. And I think we had Dr. Alvord here. Is there anything else that you need to add right now before we go to questions?
No, and Dr. Savage is here as well.
Oh, wonderful. Thank you for being here. So we also have representatives from the board. I guess let's go ahead and hear from them, and then we'll go to questions from the committee. Ms. Smith.
Okay, good afternoon. Well, we all know what this bill does, and as Delegate Johnson stated, we did meet with MPA and the delegates, and we were not able to reach a resolution. And the main issue still remains the same, that the education requirements, it's not that they don't require a doctoral degree. The actual legislation does require a doctoral degree. The problem is in the legislation, it requires, the requirements are only that you are regionally accredited. And Maryland requires approved, accredited by the American Psychological Association. And we understand that this e-passport it's designed to be an avenue to get around of not having to list that in the statute. However, the e-passport is not a product of the compact at all, of the committee. It actually belongs to ASPPB. It's ASPPB's, and it's just a ruling that ASPPB developed. So it's not a law, it's not a regulation, it's just a rule by ASPPB, which means it could be changed at any time. So as I've mentioned before, the board operates based on what's actually in the law, because we develop regulations based on the law, not based on policies, especially from an outside entity. And that would be, and the e-passport is just that. It's just a rule developed by an outside non-governmental agency, which would be ASPPB. So
do you know what the process for ASPPB changing their rules is, and what the timeline for that type of process might be?
Well, actually, we don't, because that information is not available on the website. As a matter of fact, the only place that the board's counsel was able to even find any information about the e-passport and it being related to being APA approved is in the FAQs. For your information, it's just FAQs, that's it. There's no information available other than that on the website. And that's from the board counsel, the board's counsel.
So if this rule change that we fear were to take place, though, would we have a process for removing ourselves from SIPAC?
Meaning the board?
Would the state legislature be able to, if this feared rule change were to occur, is there an exit?
The board is not so concerned with the fear of a rule change. The board would like to see it actually as part of the law, as part actually stated in the law, instead of reading regionally accredited, because the board does not license regionally accredited programs, people graduating from regionally accredited programs. So then we will have like a double system going on here. That would be pretty confusing.
Did we need to hear from Dr. Bishop? Did you have something to add too?
Well, Lorraine actually kind of discussed what the concerns from the board is that we would like to see the language in the bill to say replace the regional accredited to APA accredited.
So, and I think the challenge is the same challenge we just discussed with the previous compact bill, that we can't always change the language in a compact bill specifically, but there are other guardrails that we can put up to ensure that our intent is met. So with that, I'll see if we have questions from the committee. I see some hands up. Delegate Lewis, followed by Delegate Cullison. Delegate Lewis. I think she's on mute.
Thank you, Madam Chair. Thank you so much. Thank you to the sponsor of the bill. Thank you to everyone who came to answer questions. I want to make sure I'm understanding the concerns of the Board of Psychologists.
Mm-hmm.
It sounds like you're looking to ensure that any counselor working in Maryland meets the same standards that Maryland's board imposes.
If I can just correct that, we're looking for counselors, a different board. We're psychologists, so we were looking for because they have different rules than we do. We're looking for that any psychologist that would work and that would provide telehealth services to Maryland residents would meet the same requirement as those who are licensed in Maryland.
Okay, so it doesn't matter if they're a member of the compact. Any member of this compact living in another state, if they're going to deliver services to Marylanders, they should be subject to the same standards as a psychologist living and practicing in Maryland. They shouldn't have a different standard of training, and they should be subject to the same standards our board does. Now that makes sense to me. It sounds like I heard that right. We're not. Okay. And I also want to make sure I understand this. SPCB, sorry, I didn't get the acronym. That's the regional association.
So our standards is American Psychological Association.
Yeah, the APA I get. It was the other one with the long.
The Canadian Psychological Standard. You're talking about the Canadian?
ASPPBD, whatever.
SPPB, okay.
What is that? What is that? It's a regional body?
The Association of State and Provincial Psychology Boards. It is the association made up of all the licensing boards for psychology across the US and Canada. And I can address how the e-passport has been created and how any changes would be made to that if that would be helpful.
I think that would
Thank
be
you.
helpful.
Yeah, thank you. Mm-hmm.
The e-passport actually is a creation of ASPPB. We reached out to all of the member jurisdictions, and that is kind of where the compact came from. And I think, as everyone is aware, there are many variations for psychology licensure across the state. So the e-passport set a standard that kind of leveled out all of the licensing requirements from all the different states. It does require an APA, CPA, or joint designated program as somebody coming from is being graduated. That is in the Policies and Procedures Manual or the Mobility Committee, which is established on the ASPPB website. There is also a handout that does talk about the e-passport requirements kind of as a quick guide, as well as the FAQs that Ms. Smith mentioned. We also have a committee that works within the commission. It is called the Requirements Review Committee. It works in tandem with the ASPPB Mobility Committee, and they discuss, and the commission has the vote to approve anything that is being looked at in regards to the e-passport. When they made the decision to go with APA, CPA, and joint designated, that was brought to the SIPAC Commission. The states that sit on the SIPAC Commission, and as you know, if you're part of the compact, you have a representative that sits on the commission, they were allowed to participate in the criteria that was set up for the e-passport. So there is a process, and the two organizations do work together as far as making any changes.
Thank you, Ms. Orwig. Okay, so Madam Chair, if I may, I really want to understand this.
Sure.
Forgive me. Thank you. Thank you, Ms. Orwig. Thank you, Dr. Smith and Dr. Bishop. So this regional compact, the ASPPB, says you can participate in this, you can get this, qualify for this e-passport if you have APA certification or other certifications. So there are options there. In Maryland, our board says you must have APA certification.
Exactly.
So am I right? Did I get that right? Okay. So the regional accreditation, and forgive my terminology, but I think you know what I mean. Accreditation. You must have APA accreditation to practice as a psychologist in Maryland. That's our board's, that's it. You can get an e-passport if you have APA or some other accreditations, but you can't practice in Maryland without the Maryland standard. So it seems to me that seems fine. That's perfectly fine arrangement, but it seems to me that our board needs to be able to vet and certify those practicing delivering services to our people. And I'm just wondering, am I getting that right? That's all the board is asking. You're not opposed to the e-passport, which creates opportunities for people with lots of accreditations. That's great. But if they want, they can practice in Pennsylvania, whatever. But if they want to practice here, all you're asking is that they have the APA accreditation. Am I right? Okay. So the e-passport isn't the problem. It's the APA accreditation.
I thought that Maryland also allowed CPA and joint designation as well as part of their.
Is that
criteria.
so, Ms. Smith, Dr. Smith?
Yes, we do. Well, the CPA is equivalent. It's the same thing. It's just a Canadian association.
So if you have that CPA,
it's the
you
same
can
thing.
practice in Maryland.
Right. It's equivalent.
So that's
to
all
APA.
you're asking, is that
Yes, it's the same
anyone,
thing.
okay. I don't see the problem. What's the problem?
I think the challenge is, and I'm not sure there is a challenge, we have these compact laws and we can't change them because they're agreed to by multiple different states. So we can't necessarily amend the language of the compact. Tell me if I am correct to the representative who's here. I forgot your name already. Sorry, I'm looking for you. You were just talking on the screen. That there's no psychologists that are part of this that would fall outside of Maryland licensing criteria right now. Janet, that's as I have had it explained to me, there is nobody with the ASPPB qualifications that would not be eligible for licensure in Maryland.
My understanding, if I am reading the Maryland law correctly, because they do allow APA, CPA, or joint designation, that is the 3 requirements that you are allowed under an e-passport. So those were the same requirements.
So the concern is that in the future, there might be a change and that is not currently in the statute that we're proposing. And so what we would need to do is to get at Delegate Lewis's concern is, come up with a path for ourselves to knowingly be able to respond should there be a change in the future, and to feel comfortable that the timeline for that change in the future that we fear, that we would be able to exit from SIPAC should that happen. I think that's sort of where the committee's at. Delegate Cullison.
Thank you, Madam Chair. You put things pretty succinctly, but I have a couple of questions. So if we become a member of SIPAC, then we get on the board of SIPAC, right? We have a representation on that board. Is that right?
Well, yeah.
Yes, that is correct.
Okay, so any discussion, if we do this, then any discussion about changes in certification would have a representative of a Maryland psychologist on it, right?
Correct.
Okay. What's the process by which a state can withdraw from SIPAC?
There is a section in the compact that lays out the withdrawal procedure. So there is a process for removing yourself from the compact if something happens that you are not familiar, aren't in approval of. So there is a process laid out in the statute language about how to withdraw.
Is there any negative consequence to a state for withdrawing from the SIPAC?
I'm actually going to defer to Mr. Wolfberg for that one.
Okay.
Yeah, so the process of withdrawal is simply by enacting a statute in the same manner that statute is passed. And as far as there's a limit on withdrawal can't take effect until 6 months after the enactment of that repealing statute. So there is that limitation. And the compact also says that withdrawal doesn't affect the state's continuing obligation to comply with investigative and adverse action reporting, but otherwise, other than the elimination of the interjurisdictional privilege, which is the subject of the compact, there's no other really negative consequences. But of course, access to care and the compromise that would So I don't want to minimize it and say, oh, there's no consequence, because of course.
I'm just saying, you're not going to charge us $10,000 to withdraw from the compact.
Yeah, I'm not seeing that section in the statute.
Okay.
Payable to the compact's lawyer. I don't see that part.
Darn. Just check it, Madam Chair. One more, if you indulgence. So this is for Ms. Smith. So yes. I'm hearing very clearly that the requirements and certification are rigorous in the compact. In your letter of support for the governor's bill, you said you were willing to accept people who are substantially equivalent. I don't know what substantially equivalent means, but I'm not sure that it means exactly equivalent, which is what I'm hearing SIPAC is. So can you tell me why these are different?
Sure. Sure. First of all, that bill, the governor's bill, it's actually not a compact, as we all know.
I know.
And it actually just expands what Maryland currently does in terms of services. The equivalent piece comes about with the, as someone mentioned earlier, that there's actually 3 approvals. One is APA and one is Canadian approved. And the next one is a designation. Up until 2014, there was a program, programs, doctoral psychology degree programs were accredited by the National Register. And those were equivalent. And so anyone who graduated before 2014 from a designated program is eligible to participate. However, the designation program ended in 2014. So it no longer exists. So either you have a degree that's a designated program or you don't. So that's where that is. And we of course, we still recognize those people that graduated prior to 2014 in those programs.
So if somebody graduated after 2014, they wouldn't be eligible to work in Maryland under the governor's bill either.
No, they would not be. They would not be, exactly.
I'm not sure the governor knows that. So those are all my questions. Thank you, Madam Chair.
Okay, Delegate Krebs.
I just have a little more practical. I mean, right now, we need telehealth and we need telepsychologists and we have a shortage. And so I think the purpose of the pact is to open it up for both us to be able to operate telehealth and to be able to operate out in our surrounding jurisdictions. So I guess the question I have is, I know we have this higher standard, but is this higher standard more important than actually having more access for our constituents? And I think the whole purpose of the Contact Pact is for access, and it's for access to more providers. And right now we can't change the compact. We can't change it seems to me that discussion needs to happen once you get into the compact, and then you all professionals decide what is a reasonable training or whatever to have the accreditation, and not here in this committee. But I'm looking at access to care for the people that we represent, and there's not enough psychologists around. And as we move forward with telemedicine. So this argument about whether or not it should have certain accreditation, our standards are higher. I don't know if that outweighs the fact that we need more, we need more practitioners, and we need to do, and we're a small state and we need to be part of this compact. So I guess my suggestion is that I think that this discussion should happen after we get into the compact. And if you can convince the other states that you need to have a higher standard. I mean, I would rather see more practitioners than less. And I don't know, I personally don't know, we're talking about all these different standards. We don't know. But obviously there's 15 other states that are doing it. And I'm leaning on the side of more access than less access, and have that discussion among your compact states if you think that's necessary.
Okay, can I comment on that? Actually, Maryland has had telehealth since 2017. We were one of the first health boards to actually establish and get and promulgate regulations on telehealth. We also, we currently have a temporary exception to practice, and we had that way before the pandemic, where those from other states could actually come to Maryland and provide services to Maryland citizens, Maryland residents. So we've had that. The governor's bill, it expands that same premise.
I think the discussion of the governor's bill is not, we don't even have that in subcommittee. So let's not talk about that. Let's talk about what Delegate Krebs's point was, which is it important enough that we have this higher standard, as she referred to it, in statute versus in policy, which is what we would have with this compact? Is it worth it? Is that enough worth it to limit Marylanders' access to care?
Well, it just changes things. It just makes a change. Now that's up to the board, if they want to change the standards, or the legislators to change.
It's actually up to us. So
yes, it just changes the standards.
Up to the legislature. Yeah. Delegate Bagnall, and then we'll hear from you, Dr. Alvord.
Thank you, Madam Chair. And I'm going to try not to muddy things anymore, but I wanted to go back to something that you said, which was the guardrails, because my understanding of a compact is that that when you're practicing within a state, you still have to meet that state standards, even if you're not licensed in that state when you're a part of the compact. So I do understand the concern about changing the e-pass, but if I'm understanding it correctly, the nature of a compact is that if the e-pass standards were to change, any participant in the compact would still have to meet the standards of practice in Maryland, because that is the nature of a compact. Am I correct on that? It doesn't have to be explicit in the language of the statute because it is part of the compact agreement.
I'll be happy to answer that if I can.
Please.
That's exactly correct, Madam Delegate. The compact does not apply to intrastate practice. It only applies to the two instances in which interstate, interjurisdictional privileges are granted. So within the state, that is entirely the domain of the Maryland regulatory scheme.
Dr. Alvord, did you have something to add?
I'm just commenting as a practitioner, one office 2 miles from the DC line and the other office 15 minutes from Virginia. And at this point, there have been lifted restrictions for continuity of care, but pre-pandemic, because I've been doing this so long, I have not been allowed to provide any services in DC or Virginia for continuity of care if I'm not licensed in both of those jurisdictions. And we have so many children who are living in 2 households, many in one parent in Virginia or one parent in Maryland or DC. And the need is so huge. Not just the pandemic, but the mental health crisis is growing. And I have read the e-passport, not as a legal person, just as somebody who would have to apply. And the standards seem to be very high. In fact, somehow I'm supposed to produce original documents when I've been licensed for 40 years, which will be a challenge. But, I would hope that there are high standards. We want to keep this at the doctoral level, but we also need to have the ability as Maryland licensed psychologists to be able to continue our services if a child goes to their parents' home in DC for a week and have that ability to continue treatment. So this coming from a passionate place and not a legal place.
Thank you. Let's hear from Donna Marshall and then Delegate Johnson. Donna.
Thank you, Dr. Alvord. I just want to second what you said, and thank you, committee, for letting me share my thoughts. As a licensed psychologist in 3 jurisdictions, including Maryland, where I've been licensed for 14 years, the need is so incredibly great. I call it the tsunami of need, and it has only brought this mental health, public health crisis to our doorstep with the pandemic. Children's National, we serve more than half of our children that we serve come from Maryland. The team I oversee, just my team, and now mind you, we have over 70 psychologists that are part of Children's, many of whom practice in Maryland and have families across jurisdictions that this would definitely impact. My team alone, we serve thousands of children and family every year. And I would say more than 70% are Maryland Medicaid insured. They have less options. And then when you look at the intersectionality of systemic racism and with impacts health care and disparities there, it is staggering what we are seeing and how our kids need more. And I would also like to add, for example, I have 2 doctoral level, highly trained psychologists on my team right now who are limited and cannot serve our Maryland families via telehealth as they wait for their licensure to come through. It'll come through, but they're waiting. In the meantime, I have a psychologist who specializes in serving children who are very medically complex. These are our tech-dependent kids. These are our kids who are on traits in wheelchairs. And so families, in order to get care, because we can't this person cannot do telehealth into Maryland, not a SIPAC date. Mind you, she's already licensed through SIPAC and DC. The family now puts their child at risk. It takes hours to get the ambulance transportation arranged, to get them to the hospital, to be in front of this provider, when it would be much safer and easier for this psychologist to actually provide telehealth services to that Maryland resident. I'm sorry, I get very passionate about this because I care very much about the families I have served through Children's for the almost 20 years now. And the need is only growing, and we are doing the best we can. And quite frankly, Maryland children deserve the same quality of care and access to care and continuity of care that the children of DC and Virginia have. So thank you for letting me say that.
No, thank you. And I think we'll hear from Jen Crockett and then Delegate Cullison.
Thank you so much for the opportunity. Just to reiterate, I think what Delegate Johnson started talking about to begin with in terms of the surrounding states, and then what my colleagues at Alvord Baker and Children's National brought up. I'm at Kennedy Krieger. I'm a psychologist at Kennedy Krieger. I'm currently licensed in Maryland and in Virginia, and have applied for the e-passport. Kennedy Krieger provides such unique services to such a specialized population that pre-pandemic, those families would have gotten in their cars and gone through incredible feats to get to our physical locations. We're now able to access them via telehealth, even if they are across state lines. And this is just not the direction that we want to go after the pandemic. We do enjoy some flexibilities right now. We enjoy some temporary licensure. Many of us have gone through the process of actually getting just fully licensed in surrounding states. It's expensive. It's hard to maintain. We all have to, as a Virginia psychologist, I have to make sure I'm following Virginia rules. And if I was a SIPAC psychologist, I would still have to make sure I was following those same rules, regardless of which state I was practicing in, whether I was fully licensed or whether I was if I was providing those services through the compact. And then just the other thing, I'm so grateful that ASPPB is here. I just wanted to make sure that, it's clear that they're not a regional organization. They are the organization that does all of the licensure for psychologists, any psychologist in the country, and they the exam that we take, et cetera. And in my eyes, they really are the gold standard when it comes to credentialing.
Thank you very much. Delegate Cullison.
Thank you, Madam Chair. So after hearing a lot of this information, hearing, passionate evidence of the need, I am convinced that the SIPAC absolutely maintains the high standards that Maryland looks for, and that it gives our in-state psychologist opportunities, and it also opens up access. So I would like to move the bill.
All right. I heard a very quick second from a couple of people there. So the bill has been moved and seconded.
And a question, did we do the amendment for the emergency? Did we need to have the amendment on it as well?
Oh, that's a great point, Delegate Krebs. So let's have Delegate Cullison first have moved the make it emergency bill amendment, right?
I move to make an emergency bill.
Okay.
Second.
Okay. All in favor of that amendment, say aye.
Aye.
That's it further. Okay, perfect. Anyone who wants to oppose it, put your hand up. I'm going to assume that Delegate Riley and Delegate Cullison's hands are just up for questions. That's okay. We'll get to Delegate Riley's question in a second. Okay, so now Delegate Cullison, you want to move the bill as amended?
Move the bill as amended.
Second.
Moved and seconded by multiples. Okay, so we can have discussion on the bill now that it's been moved and seconded, but I don't see any more hands up except for Donna Marshall, and I think that's an old hand. So Delegate Johnson has something to add, it looks like. Maybe?
Madam Chair, I just wanted clarity for the committee. And please correct me if I'm wrong, Mr. Wolfberg, but when we talked about a state withdrawing and the obligations of the state to investigate or reporting requirements, that would only be effective up until the date of our withdrawal. Am I correct on that, Mr. Wolfberg?
Yes, sir, you are.
So that would not be a continuing, ongoing thing. That would just be to the date of withdrawal.
Yes, sir, you're correct.
Thank you.
Great, then we'll hear from Delegate Bhandari and Delegate Riley. Delegate Bhandari?
Thank you, Madam Chair. I really like the idea. In the meantime, I believe that this SIPAC is governed by a commission which operates under standard bylaws and regulation. And I was reading some opposition letters. I think we discussed here comprehensively, but still I have some reservation with Maryland Health Department. They say that this SIPAC do not meet the standard established in Maryland, and rigorous intensive training may or may not be there. Is there anybody to talk for this to clarify this one?
So I think that's what Ms. Smith was talking about. You know, we had because that letter is from the board, right? So it's under the Department of Health, but it's coming from the psychology board. So that was Ms. Smith sort of trying to explain her concerns about not having the standard in statute because the standard is in the policy. So that was the conversation that we had then.
Okay.
Okay. Does Delegate Riley still have a comment or a question? There you are. Yes, Delegate Riley.
Yes, thank you, Madam Chair. Yeah, I just wanted to mention, you know, I'm trying to get more school psychologists in our schools because that's where our young kids need help. And in the process, finding out that they do not have license with the board. They actually are certified through MSDE. And we're using them for our students and our children. And apparently they're very well qualified and it's a good certificate, program. And, we have a shortage on those. So, we certainly do have a need. And if we made the exception in that category, I think, somewhere it has to be possible that this accreditation with this compact, it sounds very rigorous and, very qualified. The ASAPP, or what is it? e-passport. It sounds like, these folks and these psychologists are extremely qualified. So I would hope that, the board and we could work this out and move this bill. We certainly need more psychologists in the state of Maryland. And we made an exception somewhere before. I think we could probably work it out again. Thank you.
That's a really good point, Delegate Riley. And I thank you for your work with school psychologists. It's so important. Anyone else from the committee with anything to add before we take a vote? All right, I'm going to call a vote. All in favor of the motion, which is a favorable motion, say aye. Aye.
Aye.
Anybody who'd like to oppose, please raise your hand. I see none, so the bill passes unanimously. Thank you very much to everyone and all the stakeholders for all of your support on this, for helping us figure it out. Everybody take a deep breath because we have another one coming. But I promised you a hard stop at 1 o'clock, so we will do that. So we will spend 10 minutes to discuss this. So this is House Bill 1040, which is the Vaccine Administration Bill. However, with some strong guidance from the chairman, we discussed sort of really changing this bill in a way to make sure it is hopefully, and we have some stakeholders to let in this room right now. So hopefully my staff is working on letting them in the room, but you have a reprint in your packet. The purpose of the reprint is to really, take the idea of pharmacists administering vaccines to children, which is currently happening on the ground in Maryland because of the federal order. Figure out, to use the time because of the federal order to study it, to determine if it is working, how it might not be working, if it is reducing well child visits, if it is something that is increasing access, particularly for certain vaccinations or in certain populations. So that is really the goal, is to take a very similar path to what we did with telehealth, to understand that the Department of Health has some obligations here. We are in a unprecedented health emergency, and a lot of genies are coming out of bottles, and we need to make policy decisions at the end on the way out of this health emergency that are informed, and also really figure out how to come out of this pandemic in a way that doesn't, with policies that are not going to be detrimental for our vaccination rates for childhood vaccines. We have a lot of catch-up work to do. We want to figure out what the best way to do that is both safe and in the best interest of public health. So I'm asking us all right now, as we have this conversation, to take off those health occupations hats right now. This is not a turf war bill. This is not a bill about who has the power to do what and who can make money off of doing what. You know, this committee wants to look at this bill as amended as what is best for public health, what is the obligation of the Department of Health to help us figure out how to make good policies for the purposes of public health. So with that, I know we have a bunch of stakeholders on this. We're not going to vote on this today. We're going to discuss what the reprint looks like, discuss the stakeholders' opinions, and you know, come back to this, because I know this is a complicated issue. Lisa, can you walk us through, please?
Sure. So the amendment is on page 10 of the packet that was sent around. The amendment retains current law for all of the immunization language that's currently in statute, but it adds language that authorizes a pharmacist to administer a vaccine to children ages 3 through 18 on or before June 30th, 2023, if specified requirements that mirror those that are required under the Federal Department of Health and Human Services Third Amendment to Declaration under the Public Readiness and Emergency Preparedness Act for medical countermeasures against COVID-19 are met. So it's taking the language that HHS has approved and putting it into our state law, so that pharmacists could administer these vaccines until June 30th, 2023.
Okay, so with that, that's what this is our initial crack at an amendment that was based on the letter that was submitted by Pat O'Connor. It is certainly not the bill that the retail pharmacies submitted. You know, it's changed a lot. So I'm not sure which stakeholders to call first, but let's hear, I guess, well.
Delegate Kelly, I also forgot to mention that during this time frame, that there will also be a study going on. I think you alluded.
Oh yes, very important part of it. And I know that there's, you know, we're going to need to tweak some of the language in the study, and the stakeholders will have comments about that too. So we'll just take notes and see where we can get from here. I see Robin Elliott here. So Robin, can you do you have anything to add on this? And then we'll go to Pat O'Connor and Kaylee Locklear and Aaliyah Horton also.
So thank you, Robin Elliott, today representing the Maryland Nurses Association. I have with me Lorraine Diana, and I wonder if perhaps she could say a few words about why the nurses are very interested in working with the committee on this bill.
Sure, thank you. Lorraine.
Thank you. Hi, everybody. So I think that I enjoy a different perspective than lots of people who live in Montgomery and Anne Arundel counties and Prince George's counties. I come from Southern Maryland, and as you know, we have large health care shortages there, and access to care and access to vaccines, even childhood vaccines, is a difficult topic. And I think that with regard to the pharmacist being able to help with catch-up vaccines during this crisis has been very important to children statewide, particularly in the shortage areas and Baltimore City. And that it's important to not lose this ability right now to do these catch-up vaccines. So I like the idea that extending this through June of 2023 so that no children are left behind is really important, while we study this to see if long-term we need to have the pharmacists with this capability and how that's going to interact with their well child visits, which are very important to the children as well. At any rate, I support the amendments if that's going to get the bill through for sure.
Thank you very much. So we're short on time, so I want to make sure we hear from everybody in no particular order. I think Pat O'Connor is on the call. Pat, are you here?
I am.
Okay, so I know we haven't talked before this meeting. We talked a few days ago. I haven't talked since you've seen the amendments we have. Are they consistent with what you were thinking? Do you have feedback for us that's brief, knowing that we can talk about it again on Monday?
Yes. So briefly, I do have feedback, and we are revising our impression of the bill based on the consumer testimony and the provider testimony, which raised concerns that we had not considered or been aware of. And I would say that our major concern is timing. As we point out in our letter, no statutory changes are necessary for the temporary federal order to remain in effect through the end of the order, and that is consistent with the state order. We can support a study. We think, though, the timing really matters. We favor taking serious consideration of the consumer feedback, which raised concerns, and the provider feedback. And we like the idea of allowing the orders to expire. The law as it is will stay on the books. DHMH, or Maryland Department of Health, would have time to collect the data that accrued during the pandemic, assess it, and evaluate it. Stakeholders, including consumers, parents, patients, can then be presented with that information. We can assess what unmet needs there are. And our preference would be that a public health route be taken versus an expansion of what might happen at the retail pharmacies, based largely on the practical considerations and problems that were raised and which we just first became aware of. So we're very concerned about rushing through this. It's very important, and we did not comprehend some of the risks that might be involved.
Okay, let's hear from, who else we have? Kaylee Locklear.
Hi, everyone. So I'm going to try to be brief too. Jill McCormick is here, as well as Aaliyah Horton, and I think there's a couple things that they want to hit on. I really think with these amendments, the bill is now addressing a lot of concerns that came up from the hearing. There is a sunset in the bill now where the committee and the legislature would be able to look at this study and then base a decision about making this permanent. And that's something we've talked about for years. This bill is nothing new. The majority of states already do this. This has been happening for 7 months now. So we in no way feel like we are rushing through this. Training had come up, concerns around that. I want Aaliyah to speak a little bit about that. But we also mandate in the bill that the pharmacist shall have a conversation with the parents and in that setting about the importance of a wellness visit. So we're actually going to be codifying that to ensure that conversation happens. It already does happen, but I think that that'll alleviate some concerns from folks. I know a lot of you have received information from parents that are concerned, but this is just allowing access and choice. And I wanted to refocus us on that. And then finally, and I think this is one of the most important things, it came up in committee. I've talked to a couple of people about this, but what we need to understand right now is 2 of the health departments in our state have completely ceased operations in providing immunizations for children. 2 of our counties. The rest of the counties, and we called every single one of them and spoke to them, actually now is only offering immunizations by appointment. So they have severely restricted access, especially to lower income families or families that do not have primary care physicians or pediatricians to be able to even receive an immunization. So if this federal order ups, we're in trouble here. So those are just a couple of things I wanted to touch on. Madam Chair, I'll turn it back to you.
Great. Let's hear very quickly from Aaliyah Horton. Well, Jill, we'll hear from Jill McCormick, then Aaliyah Horton, then Pam Casemeyer. Then I promise everybody will be done by 1:05, I swear. Go ahead, Jill, please. Anything to add?
Good afternoon. Yeah, I'll just be brief. I just want to make 4 points here that should alleviate some of the concerns that we heard, which frankly, some of the concerns were based on suppositions that are just not true. So 1, pharmacists are eminently qualified and trained to give vaccines to both adults and children. They are trained in school. They have practicums. They have national certification, the same that the doctors have on providing immunizations. 2, there is a proven track record of safety. We have given over 3 million vaccines in the past 5 years. Almost 200,000 of them being childhood vaccines in Maryland, and that's pre-COVID. Also, 3, we have the capability, and we do it all the time, of communicating with primary care physicians. We do it with prescriptions. We do it now with vaccines. And in fact, we do it twice. We notify the PCP if they have one, and we put it in the vaccine, the statewide vaccine registry that's always available to check. This is really about access and allowing parents to have the choice to take their child to the pharmacy to get that vaccine safely. The doctor will know about it. If they do not have a pediatrician, we will counsel them on the importance of well-child visits. So I really feel like those points take care of the concerns, any valid concerns that might be out there. Thank you.
Thank you. Let's hear next from Aaliyah Horton, then we'll hear from Pam Casemeyer, then we will adjourn. Aaliyah.
Okay, they covered a lot of my points, but one thing I do want to highlight is that I am very proud to say that in Maryland, the folks that are doing the training for pharmacists and student pharmacists in all 3 schools of pharmacy are nationally awarded, recognized vaccine and immunization experts. People from other states come to our pharmacists within our schools and in our professional practices to teach them and to lead their efforts. So we have A-class quality folks doing this work. And so I'll leave it at that. And I know we're going to have more time to discuss these issues, and we 100% support this bill. Thank you.
Great. Thank you so much. So Pam Casemeyer, if you're here, I think you're here.
Yes,
Awesome.
I am.
And just before you go, just want to thank you. I know we got an email with some thoughts on other things to be included in the study as well. I know we've got a lot of talking to do on these amendments, but go ahead.
Right, and so there is a lot of concern. There is a difference between what needs to happen during this public health crisis and what needs to be the permanent framework. And I don't think that necessarily assuming continuation of the permanent framework should be presumed. And looking at the study, and not to take too much time because I know that we're going to be talking more, there's a lot of things that are missing from the study. First of all, a lot of the data collection is all tied to school vaccines. There are multiple vaccines that are not related to school vaccines, and many of them are multi-doses. There's nothing in here that talks about managing the multi-dose vaccine and the timing of all of that. There is nothing in the study language that talks about the physical layout, framework, staffing requirements, and the like of the pharmacy, speaking to a lot of the issues that were raised by the consumers and the providers for privacy, for safety, for the ability to, when there's adverse reactions, all of those kinds of issues that need to be addressed. So it may be that it's not even the pharmacist qualification, but it may be the pharmacy layout itself does not work. Not that has to be looked at, because maybe there are those issues that need to be looked at. The local health department issue is a very important issue, because we would like to see the local health departments open back up again. And many of them will say that once they're not focused on COVID, they will be returning to the services they now provide. So we should not presume that the current status of the local health departments will continue. And they have a broader range of services. Similarly, we've done a lot of work. This committee's done a lot of work with the school-based health centers. That's another component part of this evaluation, as we're assessing capacity, access, and vaccination rates. And once again, building in as strong as possible the whole issue of well-child visits, because you're going down to 3 years old. That's huge.
Well, that's based only on the federal order. Again, this is not,
I understand that, but if you're looking to maintain it even for another couple of years after the federal, we have some concerns. I think Mrs. Pat O'Connor raised the concept of studying it, looking at all these factors, but not presuming it just stays in place while we're looking at it if the public health emergency is over. And then the last issue is we need a much more vibrant evaluation of Immunet and what is working and what is not working. You've got some language, but it probably needs to be stronger, because I hear from both the pharmacy side and the provider side that the Immunet data is not complete. And so if you aren't able to accurately know what has been given and what has not, especially when you have multiple dose vaccines, you could run into some very significant concerns. And that those concerns are even greater if children have underlying health issues or have history of adverse reactions or other things that may not be able to be described by the parent. I mean, I can tell you as a parent, I couldn't necessarily tell you the exact name of the vaccines my child got at a specific visit. And so if that Immunet registry is not 100% accurate, we've got some issues there with health. So those are all things I think need to be strengthened as we talk about what we study and under what circumstances.
Wonderful. Thank you very much. And I think we'll all be in touch over the next couple of days. We're going to meet again to talk about this on Monday, as well as 1287, 1033, 652, and coming back to hopefully pass the audiology compact on Monday. So with that, we're going to adjourn the meeting. Thanks to everyone for all of your